Hi, my name is Dr. Scott Resnick. I'm a practicing endodontist in Manhattan, New York. Today, we are going to describe the various steps of endodontics from start to finish. Endodontics is an intricate procedure for sure, but can be very rewarding for both clinicians as well as, of course, our patients. Let's take a minute to state the main goal of endodontics. It is the prevention and/or elimination of bacterial infection and inflammation associated with the canal system. From the beginning of modern endodontics, we have relied on the radiograph as a critical part of our diagnosis, prognosis, and of course treatment. Today we have an additional tool that has quickly become the standard, and that is cone beam computed tomography, or CBCT. Regarding the importance of this technology, the American Association of Endodontics and the American Academy of Oral and Maxillofacial Radiology issued a joint position statement on when CBCT should be employed. This paper starts out by telling us when CBCT should not be used. It said CBCT should only be used if the patient's history and clinical examination demonstrate that the benefit to the patient outweighs the potential risks. CBCT should not be used for endodontic diagnosis or for screening purposes in the absence of clinical signs and symptoms. The clinician should only use CBCT when the need for imaging cannot be met by lower dose two-dimensional radiography. Lowe, Dula, and Bergen et al. Compared periapical radiography and limited cone beam computed tomography in posterior maxillary teeth referred for apical surgery. They found that 34% of the lesions were missed by periapical radiography and virtually no lesions were missed with cone beam computed tomography. So how does this bear out in the real world? Well, this patient presented shortly after a traumatic injury to the maxillary anterior teeth. You can clearly see a slightly widened PDL on tooth number 8 and radiolucent lines indicating possible fracture. It does not tell us the extent of the likely fracture and does not tell us if it is buccal or lingual. It does not tell us a lot of things because it is a two-dimensional picture of a three-dimensional object. But when we take a cone beam, we can clearly see the extent of the fracture line. We see how far below the crest of the bone it extends and whether or not to even attempt treatment, saving the patient time, pain, and of course, money. Today's patients have higher expectations and are more knowledgeable. And as clinicians, the more we know, the more responsibility we have to give them the treatments they deserve. This is another case that illustrates the efficacy of cone beam when dealing with complicated situations. What we have here is an endodontic failure, and it looks like a pretty straightforward failure, perhaps even one that I would make a small access through the existing crown and then place a post or replace the crown. It looks like there is a diffuse radiolucency at the apex, a slightly widened PDL, and a tooth that perhaps we should consider for retreatment. And if not retreatment, then possibly an apicoectomy. That is, of course, until we took a cone beam and saw this fracture line in the tooth. There is no way you could have ever predicted a fracture like this using conventional radiography. Another really great example of the importance of cone beam is in the diagnosis and treatment of resorption cases. This is the resorption guide from Jeffrey Hithersay, and it shows the 3 classes of ECIR, or extra canal invasive resorption. Class 1 is treatable, Class 2 may be treatable, Class 3 is probably not treatable, and Class 4 is clearly not treatable. A two-dimensional picture of a three-dimensional object does not really show us much, and the previous dentist reflected the tissue, made a small access prep, filled it with amalgam, and then put the tissue back in place. 1 year later, the general dentist took this radiograph, showing evidence that the lesion had grown. He then referred the patient to us, and we, of course, immediately took a cone beam, which not only showed the extent of the lesion, but that it had spread to the lingual aspect of the tooth. This helped us illustrate to the dentist and to the patient, who was adamant about trying to save the tooth, why this lesion was much too extensive to consider treating. This is a patient who presented to us after access was made by a general dentist. The general dentist, at this point, felt uncomfortable about finding all of the anatomy and wanted to stop before there was a perforation. He knew they were close, and so he sent the patient to our office. We, of course, took this radiograph and were a bit alarmed by how deep the access was relative to the furcation, so we took a cone beam. On the cone beam, we can see the extent of the access. We can see actually how close it comes at its deepest point to the furcation in all dimensions. We were able to determine that although the access looks pretty deep, we are still in intact tooth, and in fact, it's a tooth we should be able to save. We can look at this in increments, working our way up the canal to see exactly how patent the canals are, where they are, how much further we have to drill to get to them, and all of this will greatly enhance our ability to get the result we want. This case illustrates the importance of cone beam in endodontics as much as any other case we could show you. This is a root canal done by a general dentist who subsequently placed a post and a long span bridge. 6 months later, there is now radiographic evidence of pathology, the patient is uncomfortable, and the dentist sent him to our associate, Dr. Courtney Lindenberg, for an apicoectomy. As part of her exam, she took a cone beam. What she found was that there was actually a second root that had never been treated, and you can see it here. You can also see the radiolucency at the apex. So rather than remove this tooth or perform an apicoectomy, she elected to make a small access through the porcelain bridge and treat just the missed canal. Her patient saw immediate results, and as this 6-month radiograph shows, there is evidence that the lesion is shrinking. This is an article by Sergio Cutler where he took 12 random extracted mandibular molars, cut off the distal root, and then randomly selected 2 of the 12. Took radiographs, and from the radiographs, you can see they look pretty similar. He then did a micro CT scan of each. Look how dramatically different the anatomy is. You can never tell that from the radiograph, but that is what we are facing so often. We cannot possibly know from our instrumentation exactly what we are dealing with. Micro CT scans are dramatic in that they show us all of the additional portals of exit and how complicated the anatomy is. This gives us a better understanding of why it is so important that we not only instrument teeth well, but irrigate well and use proper irrigants that will remove the tissue and the biofilm from the canal walls. Now, not everyone is going to go out and buy one of these machines, but it is likely that your local endodontist either has one or knows where to send their patients. In our time, it is hard to fathom a discussion on endodontics without magnification on the order of a microscope. No study illustrated this more to me than the Burley-Barrow study of 2002. It showed how difficult it was to find the mesial-buccal number 2 canal of the maxillary first or second molar without magnification. The canal, which we all know is found somewhere around, let's say, 85% of the time, depending on the literature, well, without magnification, they found it 17.2% of the time. If you added magnification, you were up at 62.5% of the time. An incredible jump. If you then look at how often you would find that fourth canal if you were using a microscope, you would be around 71% of the time. One more illustration. This is the back of a $5 bill showing the Lincoln Memorial, and that is at 2.5 times magnification, which is pretty typical for loops. This is at approximately 15 times magnification using my microscope. I would say that this is a pretty significant difference in magnification and something we should all consider when delving into endodontics. To illustrate even further the importance of technology, I would like to show you a few research papers that really bring home the extent of what we are dealing with and why it is so important to embrace new technologies. In a research paper by Carpenter and Associates, they found a mid-mesial canal in the mandibular first and second molar 18 to 22% of the time. And Fan, in his 3D modeling article, found that 85% of mandibular first and second molars have an isthmus in the apical 5 millimeters. Clearly, there is a potential for a large percent of endodontic procedures to fail due to complicated anatomy present most of the time. I mentioned Fan's article on the complex apical anatomy in the mesial root of mandibular first and second molars. This is an illustration from that article, showing how complex the anatomy is. In conclusion, we certainly can recognize the complexities that root canal treatment has to offer. However, with the advancements in today's technology, we can appreciate our newfound ability to treat such complex situations with greater ease and confidence. As I mentioned earlier, it is my belief that there are certain steps in a root canal procedure that are absolutes. I want to thank all of you for spending your time with me today, and I wish you and your patients all the best.